All right, party people, we are back at it with another one. Let's get it. So today we're going to get into some nephrology. If they give you a 50-year-old dude with congestive heart failure and decreased urine for the last month, and then they ask you about his labs, specifically his serum BUN as well as creatinine, and his urine sodium as well as urine specific gravity. Now, first and foremost, let's get into pre-renal azotemia. In this case, the congestive heart failure is very high yield for pre-renal etiology. If the heart isn't pumping effectively, it's not perfusing the kidneys effectively. Therefore, even if the plasma volume is technically normal, the kidney interprets this as being underperfused. So they say we need to reabsorb more fluid to compensate. So what happens? The PCT increases reabsorption of sodium and urea, and as far as sodium, this is reabsorbed and water follows. The net effect is urine becomes more concentrated. Now, some students get tripped up here because they think if sodium is being pulled out of the urine, how does that make the urine more concentrated? That's a legitimate question. However, there is an answer. So sodium itself doesn't determine urine osmolality. It is the extra water being reabsorbed early in the nephron that makes the urine more concentrated overall. You need to remember this. So the key labs in pre-renal azotemia is a BUN creatinine ratio of greater or equal to 20. Now your FeNA, your fractional excretion of sodium, will be less than 1%. You will have a high urine osmolality and high specific gravity. This is what is responsible for the concentrated urine. Now, in terms of specific gravity numbers, you need to kind of get yourself organized in terms of these ranges. So let's clarify. 1.001 to 1.005, this is maximally dilute urine. I want you thinking of diabetes insipidus or psychogenic polydipsia. As far as 1.025 to 1.030, this is very concentrated urine. So we're thinking about SIADH or severe dehydration. Now in pre-renal, you want to expect high specific gravity. If it's low, that's dilute urine. Next up, we're going to get into intrarenal causes. The most important intrarenal cause for your licensing exam is ATN, acute tubular necrosis. Now, classic nephrotoxic drugs are aminoglycosides such as gentamicin or cisplatin. Now, ischemia is also high yield. So for an example, if they give you a patient during surgery and they have severe blood loss, the blood pressure drops to 40 briefly, the kidneys become underperfused, this results in ischemic ATN. Now, another example is if a patient has VFib. Let's say pops into VFib for 30 seconds, kidneys are starved of oxygen, and ischemic ATN ensues. Now, why does this occur? It's because the PCT has tons of ATPase pumps with high oxygen demand. When they get starved, tubular cells slough off, and this results in ATN. Now, as far as NSAIDs, these are not a direct cause of ATN on your licensing exams. They cause pre-renal azotemia, or with chronic use, analgesic nephropathy / interstitial nephritis. In this case, you will see eosinophils. As far as beta-lactams, cephalosporins, NSAIDs, this is interstitial nephritis. For gentamicin, cisplatin, ischemia, IV contrast, and myoglobinuria, or in the case of rhabdo, this results in ATN, acute tubular necrosis. Now, key labs for ATN, you need to know that BUN creatinine ratio is less than 20. Your FeNA will be above 1%, and your urine will be more dilute, so you'll have a lower osmolality / specific gravity. Now, here's a subtle point that you need to remember. So on the licensing exams, a significant portion of the time, BUN creatinine ratio does not match your expectations. So, for example, pre-renal cases might show a BUN creatinine of 19 instead of above 20. Intrarenal cases might be 17 or 18 as opposed to less than 15. So in these cases, your FeNA is more reliable than BUN creatinine. If they make you pick, you will go with FeNA over BUN creatinine since it's more reliable. Don't mess that up. Now, as far as post-renal causes, here we want to be thinking about BPH, cervical cancer, which is impinging on the ureters, or urethral strictures. Now, you'll have some textbooks and you'll have some resources talking about distinctions between BUN creatinine ratios, such as intrarenal less than 15 or post-renal 15 to 20, but it's not consistent, so you can't really go by this. You'll get questions wrong. In reality, Anything pre-renal usually shows bun creatinine under 20. And again, you want to be using FeNA as your guide for these questions, since it's more reliable than bun creatinine. Now let's spin the block, do a quick little recap. For pre-renal, we're thinking congestive heart failure, NSAIDs, diuretics. Your bun creatinine ratio will be above 20, your FeNA less than 1%. You will have concentrated urine, high osmolality, high specific gravity. For intrarenal, we're thinking ATN from ischemia, gentamicin, cisplatin, rhabdo, or IV contrast. Your bun creatinine will be less than 20. Your FeNA will be over 1%. You'll have dilute urine. As for postrenal, BPH, cancer, and strictures, labs can vary, but it definitely will not be pre-renal. So this may be confusing at first, but the more you see it, the more automatic it becomes. You have to remember, congestive heart failure, this is classic pre-renal. Kidneys reabsorb sodium, urea, and water. You'll have high bun creatinine, low FeNA, and concentrated urine. For ATN, you'll have classic intrarenal. Tubules slough off. This results in low BUN creatinine ratio, high FeNA, dilute urine. All right, that's it for this one. If you like the video, comment, share, and subscribe. I'll catch you in the next one. Go crush it.